Welcome to our second lecture on hemolytic anemia. Let's begin. We'll be covering hereditary spherocytosis and G6PD deficiency. Let's start with hereditary spherocytosis. We will review hereditary spherocytosis by going through its definition, pathophysiology, clinical presentation, diagnosis, and management. In hereditary spherocytosis, red blood cells lose their membrane structure to become round in shape instead of biconcave. It is inherited in an autosomal dominant fashion. Hereditary spherocytosis is caused by defects in red blood cell cytoskeleton membrane proteins, including ankyrin, spectrin, band 3, and protein 4-2. This weak red blood cell membrane does not allow the cell to maintain its normal shape, so the cells are spherical instead of biconcave in shape and are called spherocytes. Spherocytes are unable to pass through splenic sinusoids due to their relatively large size, so they're consumed by splenic macrophages, causing anemia due to extravascular hemolysis. This is a blood smear from a patient with hereditary spherocytosis. We can see many spherocytes, for example here. Notice that there is no central pallor in this red blood cell, and there are many around it that are similar. Patients with hereditary spherocytosis present with signs of severe form of anemia consistent with extravascular hemolysis, including jaundice, sphenomegaly, and elevated unconjugated bilirubin. Hence, they are also at increased risk of pigmented gallbladder stone formation. In a patient with hereditary spherocytosis, the blood smear will show spherocytes, as we have already seen in an image. On further analysis, there is decreased mean corpuscular volume, MCV, elevated mean corpuscular hemoglobin concentration, MCHC, and elevated red blood cell distribution width, RDW. MCHC is increased because there is a decrease in water content in the red blood cells, but the hemoglobin content remains the same. This increase in MCHC is fairly specific to hereditary spherocytosis. The RDW, or red blood cell distribution width, is increased because there is a higher variation of red blood cell sizes. Patients with hereditary spherocytosis will have a negative Combs test because it is the fragile red blood cell shape, not antibodies, that is leading to hemolysis. For diagnosis, we use the usmle maleimide binding test, which detects the intensity of binding between usine dye and the red blood cell membrane. Patients with hereditary spherocytosis will have decreased binding and therefore decreased mean fluorescence with this test. The osmotic fragility test and acidified glycerol lysis test that use the fact that spherocytes are more susceptible to hemolysis to diagnose the disease. The red blood cells are exposed to hypotonic solutions, which cause the red blood cells to take up the solution as they try to equilibrate. Since spherocytes are more fragile, they will burst. However, these tests are not very sensitive or specific, so typically the usmle test is preferred. Let's move on to the management of hereditary spherocytosis. Most patients require no treatment. Folic acid replacement is needed for patients with moderate to severe hemolysis and pregnant women. Blood transfusions are provided when necessary. Splenectomy is considered in patients with severe hemolysis. However, it's important to remember that patients with a splenectomy will continue to have spherocytes. They will just not have hemolysis once the spleen is gone. Simultaneous cholecystectomy should be considered if there are gallstones. It's important to ensure that all vaccines against encapsulated organisms are administered on time before splenectomy. Now, moving on to our next topic, glucose-6-phosphate dehydrogenase deficiency, or G6PD deficiency. We'll cover G6PD by going through its definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. In glucose-6-phosphate dehydrogenase deficiency, there is an inability of red blood cells to handle excessive oxidative stress due to the absence of the key enzyme G6PD, which is involved in the generation of fresh NADPH. This inability to handle oxidative stress subsequently leads to hemolysis. Glucose-6-phosphate dehydrogenase deficiency is an X-linked recessive disorder commonly seen in African and Mediterranean populations. So, decreased G6PD leads to decreased NADPH, which leads to diminished levels of reduced glutathione. This results in increased red blood cell oxidative injury and intravascular hemolysis. Similar to sickle cell disease, G6PD carriers are protected against malaria, which explains why this pathology is more common in patients with African or Mediterranean ancestry. As we can see in this flowchart, when there is deficiency of glucose-6-phosphate dehydrogenase, production of the reducing chemical NADPH will be decreased. Decreased levels of NADPH will result in decreased production of reduced glutathione. Hence, hydrogen peroxide levels will increase, which means there will be more oxidative stress in the red blood cells. Therefore, these red blood cells will be less likely to survive in times of increased oxidative stress. Causes of increased oxidative stress that can lead to hemolysis in a patient with G6PD deficiency include infection, eating fava beans, and taking certain medications, such as sulfa drugs, primaquine, and dapsone. A patient with G6PD deficiency will present with fatigue, back pain, and dark urine after oxidative stress. The dark urine occurs secondary to increased bilirubin excreted in the urine. Lab values after exposure to oxidative stress will be consistent with intravascular hemolysis. These findings include decreased haptoglobin, hemoglobinuria, increased LDH, and increased unconjugated bilirubin. On a blood smear, you'll see Heinz bodies and bite cells. Oxidative stress damages the hemoglobin within red blood cells, causing the denatured hemoglobin to aggregate and form Heinz bodies. Heinz bodies are then removed from red blood cells by splenic macrophages, which then form bite cells. The specific test we use to diagnose G6PD deficiency is G6PD enzyme analysis. Here is a blood smear from a patient with G6PD deficiency. Notice the blue dots within the red blood cells denoted by the lines. These are called Heinz bodies and are clumps of damaged hemoglobin aggregated within the red blood cells. Here's another blood smear where we can specifically see a bite cell from a peripheral blood smear of a patient with G6PD deficiency. We can see a bite cell here and a Heinz body here. Remember that the bite cells occur due to splenic macrophages attempting to remove Heinz bodies. A 41-year-old Greek man comes to the physician due to back pain, dark urine, and fatigue for the last day. He has had a purulent cough and high fever for the last 3 days. The complete blood count shows a hemoglobin of 10 and a normal MCV. Haptoglobin is low, while LDH and indirect bilirubin are high. Peripheral blood smear shows dark blue circular inclusions in the red blood cells. Some red blood cells have a unilateral concave membrane deformity. What is the best explanation for this patient's peripheral blood smear findings? This Greek patient presents with back pain, dark urine, and fatigue for the last day. He has hemolytic anemia, evidenced by the hemoglobin of 10, normal MCV, low haptoglobin, and high LDH and indirect bilirubin. His current symptoms started after pneumonia, suggested by purulent cough and high fever. All these findings are consistent with the diagnosis of G6PD deficiency. G6PD deficiency is further supported by the peripheral blood smear findings. Dark blue circular inclusions in the red blood cells represent Heinz bodies. A unilateral concave membrane deformity, on the other hand, represents bite cells. Heinz bodies are caused by precipitation of oxidized hemoglobin. Bite cells, on the other hand, are formed when the splenic macrophages remove Heinz bodies along with a part of the red blood cell plasma membrane. Now let's move on to treatment. The mainstay of G6PD deficiency management is to avoid triggers of oxidative stress. When a hemolytic episode is induced, it cannot be reversed. However, the agent that caused the episode should be identified and removed as soon as possible. Blood transfusions can also be performed when necessary. A 14-year-old girl is brought to the physician by her mother due to progressively worsening fatigue and shortness of breath for the past year. Her family history is significant for hemolytic disease in her father. Vital signs are unremarkable. The physical exam reveals yellow skin, discoloration, and splenomegaly. Laboratory findings are significant for hemoglobin of 9.5, MCHC of 50%, usmle maleimide, and acidified glycerol lysis tests are positive. Abdominal ultrasound reveals multiple gallstones. Which of the following is the definitive treatment option for this patient's condition? A. Bone marrow transplantation. B. Splenectomy. C. Blood transfusions. Or D. Folate supplementation. This young girl presents with progressively worsening fatigue and shortness of breath for the past year. She has a positive family history of hemolytic disease. Physical exam reveals yellow skin discoloration, also known as jaundice, and splenomegaly. She has anemia with a hemoglobin of 9.5 and MCHC of 50%, which is high. Usmle maleimide and acidified glycerol lysis tests are positive. Family history, high MCHC, and positive test results all indicate hereditary spherocytosis. Hereditary spherocytosis is an autosomal dominant defect in red blood cell membrane protein. This causes formation of sphere-shaped red blood cells without central pallor. These spherocytes are perfectly functional for transporting oxygen. However, they are hemolyzed by splenic macrophages due to their abnormal shape. Therefore, splenectomy prevents hemolysis and is the definitive treatment option for the patient with hereditary spherocytosis. Therefore, the correct answer is option B. Again, here's the management of hereditary spherocytosis. Pause the video and take a moment to consider this slide once more. Let's now discuss why other options are incorrect. Option A is incorrect because bone marrow transplantation has been shown to have an unfavorable risk-benefit ratio in patients with hereditary spherocytosis. Additionally, red blood cells maintain their function of transporting oxygen. The only problem is that they are hemolyzed due to their spherical shape. Therefore, there is no need for bone marrow transplantation when splenectomy is less invasive and a more effective strategy. Options C and D are incorrect. because although patients with hereditary spherocytosis may receive blood transfusion and folate supplementation, none of these are the definitive treatment options. Instead, they provide symptomatic relief. And that concludes our lecture on hereditary spherocytosis and G6PD deficiency.